I'm Dr. Michaeli. I'm a peripheral nerve reconstructive surgeon, and we're going to talk about neuromas today. So what is a neuroma? A neuroma is a benign, so non-cancerous mass of a nerve. There are two kinds of neuromas. You could have a stump neuroma, which is when a nerve is cut. And then you have a neuroma at the stump that you may have the rest of the nerve nearby, or you might have no rest of the nerve, and like in the case of an amputation. You can also have something called a neuroma in continuity. So let's say like a portion of the nerve was cut. Well, then you'll have a neuroma that's formed within the nerve, and there may even be fascicles crossing it. Those are actually the most difficult to treat because oftentimes you don't want to damage those actual fascicles. In severe debilitating pain cases, sometimes we risk that. How do these normally form? Well, they form from nerve trauma. It could happen from a nerve getting cut. It can happen if you crush a nerve, and it's really going to be the disorganized regeneration of axonal tissue. If the nerve is cut, the axons want to grow somewhere. So if it has a recipient, it will grow towards the recipient. But if it doesn't have the recipient, it will just start shooting off offshoots of nerves. And if it comes close to the skin, you might have profoundly sensitive skin. The touch could just burn. It might just itch. If it's a little bit farther from the skin, you could end up with an area that's just extremely tender. So every time something touches you over here, let's say a radial nerve neuroma, you might have extreme pain. You might have electric shocks. In the foot, people often feel like a ball between their metatarsals. They have a Morton's neuroma. Surgical wounds, another common thing. So if somebody has a surgery and they have a painful scar, it's usually going to be a neuroma trapped within the scar from a cutaneous nerve. What do we do about neuromas? Well, resect the neuroma and fix the nerve. So let's say you have both ends. That's really the only time it's an option. So we can treat it like a nerve laceration once we've removed the neuroma in a perfect world. Oftentimes the gap is too big though. So it's very unlikely that we could mobilize the nerve enough to meet each other when you've resected a neuroma. So oftentimes I'll use a nerve graft to bridge that gap, and then it's just like any nerve laceration. Sometimes you could try to preserve, so you get the microscope and we do an intrafascicular neurolysis. So we open up the nerve itself and actually microscopically dissect the internal parts of the nerve, kind of like the organs of the nerve. So surgery within a surgery within a surgery, in order to separate the neuromatous fascicles, which is just disorganized, they don't actually look like fascicles, from healthy fascicles. And then we will graft the fascicles that are present. What if it's just a stump neuroma? So we see these, for example, in amputees. Then we pair with a reconstructive procedure. The premise of these reconstructive procedures are all more or less the same. You need a living deinnervated muscle. Why deinnervated? Well, the muscle itself, when it's deinnervated, will actually send out trophic factors and signals where it's trying to receive a nerve. This differs from the historic dunking a nerve in the muscle because then you have an innervated muscle, so you just end up with a neuroma inside the muscle. When you deinnervate the nerve will actually neurotize that muscle. So one operation is called a targeted muscle reinnervation, where we cut a motor input into a muscle. We take a sensory nerve that was a pain generator, or we removed the neuroma, or it was already cut and for whatever reason you can't fix it, and you reattach the sensory nerve to the motor nerve. And then you create what I kind of call a road to nowhere. So it's creating this useless motor signal that doesn't work anywhere, but it's giving the nerve something to do, so it's not generating pain. Similarly, we could do something called an RPNI, which is where we take a very small cuff of muscle that's healthy, but it needs to be so thin and small that it's able to survive just by the oxygen tension and blood flow to neighboring tissues. So it's almost like a graft. It's a free graft. That will get both vascularized anew and innervated by the nerve. More recently, a lot of us are doing what's called a VRPNI, which is a vascularized RPNI, or regenerative peripheral nerve interface. And that's when you take a cuff of muscle, you free it up from all the surrounding tissue except for blood vessels, so that way it remains vascularized. Now the nerve can actually reinnervate that piece of muscle. You still have a blood vessel going to it to keep it alive. These are all very good surgeries. They're approximately 80% successful at decreasing neuromatous pain. These are very safe operations. Usually I tell patients it can take up to 3 months to actually see it work. However, a lot of my patients on day 0 already feel a lot better. They'll feel pain from surgery, but they can notice that it is different from the pain they had pre-surgery. And it's usually very encouraging when they tell me that. After the surgery, it's a narcotic-free practice. So they don't get any narcotics. It's Tylenol and Advil. You're moving right away. You go home the same day in 99% of cases. That's pretty much my algorithm for neuroma care. Resect the neuroma and reconstruct the nerve.